They sick.
He's sick.
They talking about change their life.
Hello, Carlos.
Hey,
David,
Hey, I hear you.
hello.
I can see you guys.
How you doing?
All right.
All right.
Carlos, you should have told me I need to lose some weight. I'm like, that man, that's chicken fat.
How are you? I just met you this morning. Just so, for those of you who can hear me, we're doing a double session, more or less. We have the session that we normally do here at Team Tony, and we also have a group meeting at the same time, simultaneous, at the Bay First Bank in Newtown. So it's kind of an exciting proposition. And Carlos and I are trying to.
Actually, got that I know.
I didn't know that.
He went over.
I didn't know that.
He's running 10 minutes late, unfortunately. David, not sure he got it.
Are you gonna?
Hi.
Hi, how are you?
Good, how are you?
Hey, look who's here. Hey, stranger.
It's been a long time,
Yeah, say hello to some of the guys.
Hi, yes, I'm here.
There's a good place to sit here.
Probably, maybe go right around to the end of the table there, would be the best spot. Yeah.
What was going on Martin Luther King? Is he over there too, or what?
Yeah, we have a group. You can see, the fourth camera down over there on the right is a group in, Newtown.
Newtown where?
Newtown, Sarasota. Newtown is a section of Sarasota. It's, actually historically, it's probably the oldest, section of Sarasota. And it's largely a black community, but it's very historically significant in a lot of ways. We have reached out to that community to try to emphasize the fact that medical services don't often get to places like Newtown. So we're trying to help that process a little bit. We've had quite a few meetings in Newtown itself. It's worked out very well. Oops. Waiting room over. 10 minutes late. Is it 2 o'clock?
Yeah, a few minutes left, 1:58.
Okay.
I invited a couple of people to
Hey, John.
How are you?
How are you?
Hi, how are you?
By the chair?
Still taking?
No, it isn't, no. I'll move around the corner here a little bit.
So did Senator get Cassie? Did you get my note?
I did, yeah, I sent you a note back right away.
I didn't get the.
Yeah, I saw your note. Yeah. It's a good thing I went there. I spent the morning there because I was afraid somebody might come by. Sure enough, one guy came.
Not at 5 to 12, like I do.
Yeah, I know.
He's coming from Bradenton, so.
Yeah. 159.
I was in Charlotte earlier, heading down. No, well, I don't know what happened on the northbound side, I was going south. It was so backed up. I thought, wow, and you can never see what happened, right? I mean, it's just like, what are they doing? But I was just holding my breath, it would be gone by the time I left, but it was.
Well, they're doing this major construction right there, so, you know, so people don't pay full attention. They're coming long distances, and then all of a sudden, they get an instant backup, and you get these like rear enders and all these other crazy things.
Yeah.
I was stuck in one also coming northbound the other day. I don't know if I was in it or not. I got so frustrated, I did like a Meridian U-turn and went off Laurel Road. I came and took 41 down. It was crazy. I was
Yeah.
literally standing.
She's gonna be mad.
Yeah, it was just like,
Oh, good, I know, I've seen that. That one was bad, because I was on it last week with a big backpack. But I've almost made that my routine now to get off on Laurel just
Yeah,
because
yeah.
you never know.
well, I wasn't gonna get it off, but I had to pick my daughter up at like, in a half an hour, and I knew that I would miss it. And so anyhow, I took the chance of doing this radical move.
Yeah.
Well, guys, maybe we should get started. It is 2:00. Hopefully, everybody can hear us and hear me and hear each of us from this room. Carlos, I have you shut off just to keep the noise factor down. But I'll open it up whenever you have a question. What we're doing today, by the way, it's kind of a new twist where we have two groups meeting at the same time. And Dr. Fitch is on his way. He explained he ran into a little difficulty. It's going to be about 10 more minutes. But I know you'll enjoy his presentation. He's a phenomenal doctor and a wonderful guy. And he will answer virtually any question you can think of. So we'll look forward to seeing him when he arrives. But in the meantime, why don't we do this? As I mentioned, we've got two groups, so we'll try to coordinate it as best we can. Carlos Yancey is in charge of the other group, and I'm in charge of this one, so we're trying to put together our technical skills, which together are not very great, but somehow we'll manage, I'm sure. And I thought it might be interesting to just go around the room real quickly and describe our own personal situation, fairly briefly, because I don't want to take a lot of time up on it, but I think it'd be a useful tool so we have an idea of where we are. And just to start off, I'll tell you my story very quickly. I was diagnosed, I guess about 8 years ago, with Gleason 8 scores, and had previously been diagnosed with Gleason 6, and I went on watchful waiting for 4.5 years, very aggressively, I might add. And it turned out that my Gleason scores, by the time I did a second biopsy, were up in the 8s. So it was time to do something, and I chose to do radiation therapy, and under Dr. Sylvester, combined that with hormone therapy and brachytherapy. He said, we're going to throw the whole shooting match at you because at Gleason 8, you're in a pretty high risk area. And so I did it, and after the end of that, of 38 weeks or whatever it was, 38 days, sorry. Not really any worse than it was. I felt great during the whole period of going through it, never felt any really bad effects, was able to go out and play tennis every day, was able to manage my life, work, and so on, and got through it. And here I am now 6 years later. How are you? Good to see you. And hanging in there pretty well. Just came through a heart procedure about a month ago, so that adds to the complications, but I know we all have got more complications than any of us want. But that's my story. So I don't know, do you want to, John, tell your?
Yeah, I'm sort of in the situation where you were years ago, in that now I'm in a wait for watching posture. I had a Gleason score of 6+7, and PSAs have been sort of fluctuating between 6 and 9, and so so I'm still not at that point where I pulled the trigger on any particular treatment. I've been exploring all different ones, from to CBD therapy, and just trying to avoid going under and being radiated at this point. So I'm still in a constant discovery pattern right now, and that's where I'm at right now. So these meetings have been really helpful to me because I can talk to people of a similar mindset and try to explore different avenues.
Mm-hmm.
That's where I'm at.
Yeah, I just completed 20 days of external beam radiation therapy 2 months ago. So, all I know. So, be finding some more out, you know, in future visits for the doctor.
Yeah. You and I are on similar paths, slightly different, but kind of similar in the view of the treatments that we have and so on. Yeah. And how about you?
I was diagnosed in January with Gleason 7, and basically I'm in my PSA 6 plus, and I'm basically researching. Now I'm trying to determine what to do next.
Yeah. I was there. I guess most of us were there, and John.
I'm right there.
Yeah,
But it's been 2 years now for me, and it's been
yeah,
kind of hard because I haven't, with the COVID and everything, I haven't been able to follow up on doctor's appointments that I wanted to, and that's been kind of a little on the scary side.
When did I get my prostate out?
And I was trying to get through with one of the speakers that we had here, Dr. Ackery, and he's fallen off the face of the earth, so.
we found him.
Oh, did you?
I know.
Yeah.
Oh, yeah, so anyhow, so.
Yeah.
Because I called Florida Urology, and now I like talking to him, he's a straight shooter, and I felt I had a good rapport going with him, but now that I had, when I called Florida Urology, they were like, you think that they put him on the hit list at that point, so anyhow.
Yeah. Well, we've experienced some good doctors, all of us have, and we've got a lot of thoughts that may help you as you go through the process. And the process is a tedious and difficult one, but it's important. And you're absolutely doing the right thing by trying to figure it all out. What's your story, Ken?
Well, my story, Ken, is Ken Keating, and become about 10 years, and I just come for the food.
There you go.
Actually, I just come for the education. I had no issues like down that situation. It's been a learning experience, a lot of different things.
You have no prostate?
What's your story?
Yeah, I got diagnosed in September last year, Gleason 6, and I had a doctor up there which wanted to get me under a knife as quick as he could. So when I came down here, I actually found Dr. Ackery, and I just got an email saying he went to his own office. I believe it is. So he did an MRI about 2 months ago, a month ago, and he said it looked pretty good, so I'm on active surveillance right now, and just checking in on the options in case that changes.
But how much of this is hereditary from one generation to another?
A good deal of it is, it appears, yeah. Yeah, it's one of the things the doctors look at when they talk to you about it, is what's your history, what's your family history of the disease. In my case, my father had it, my brother has it now. And my kids, 3 boys, I'm very concerned about, but they're young, so. But gotta keep them on their toes.
There's nothing I can do about it. I mean, try to prevent it ahead of time, huh?
Yeah, well, stay ahead of it and treat it as quickly as you can. Yeah. Not too many preventative things, really. Well, good health, keeping yourself in good condition, a lot of those things are pretty critical.
Is it looking for a certain gene that causes it or anything?
There are, the people that do the genomic testing can tell you a lot about that. We've had a speaker come in and talk about that, genetics, the whole scheme of things there.
I followed up on that, and
Yeah, you and I both did.
screening on that too.
Yeah.
So that was, they said that they didn't see any pattern. That's it, but my mother died of cancer, and my sisters had forms of breast cancer, so it's, there's a cancer situation around that, so.
Osprey over there?
Yeah, behind the hospital?
Yeah.
Oh, it's part of SMH, really, right?
Oh,
It's part of it, yeah.
Yeah.
Dr. Fitch can speak to that as well, he can tell you.
Yes, yeah, that's a good question to ask of him, yeah. Let me see if I can get Carlos in here. Where are you, Carlos?
When you work with the doctor then?
Yes, I do, yes. Yep, for about 10 years.
You gotta know who you work with, maybe.
Yep, sorry, yep. Yep, long time. He's really good. I will never need him for that reason. Thank God. Got other problems though, right? So.
Do you work in the lab with him? Do you, does he
No,
have that?
actually, I do all of his public relations, marketing and programming and things like that.
Yeah.
Although he and David now have a really good relationship, so I don't have to really intervene.
Okay. You should be here now. Okay. All right. Hey, can you hear me, Dave?
No, I had missed the visit.
I can hear you.
Okay, great. I ended up coming down to the Newtown place. I got the flyer and I thought everybody was gonna be here, so we'll just do it from here.
Oh, where is he? He's still there?
He's at Newtown.
Oh, he went to there. Okay, well.
Is that you, Linda?
Yeah, David, I'm here too.
Hey,
Oh,
Fitch.
I knew that this would be confusing for people. Dr. Fitch, welcome.
You guys can hear me okay?
Yeah.
You're standing right now.
Can you get close to the microphone over there, Dr. Fitch? And
Yeah, where's the microphone? Over here?
I think you have to be fairly close to the to Carlos's
It's
computer.
coming on
Okay.
my.
How about now?
I think that's pretty good,
Getting
yeah,
better.
yeah.
Okay, we'll just do it right here then.
We can't see her.
I'm sure y'all can see me, but that's fine. Where's the camera? The camera. Is it all set up to here? Oh, yep, that's what it is. Okay, so what I'll do is I'll just do this. I'll sit down here. See me.
We can see you very.
All right, how's that, everybody?
I think that's great. yeah.
Great, good to see
Okay,
you.
great. Great, okay.
Welcome aboard.
How's everybody doing?
Great, good.
Okay, good. Sorry for being a little bit late, my apologies.
That's all right.
Happy as everybody was able to get to either a computer or get here in person. Again, I think I met a few of you before. My name is Dr. Dwight Fitch. I'm a radiation oncologist, primarily in Bradenton, but I've spent lots of time through Sarasota as well, particularly Newtown. So basically what I want to do today, keep it pretty casual. You know, much of it will be sort of questions and answers. And I find that a lot of times that a lot of people have the same sort of questions. So, you know, no one be shy. We'll get those things answered. One thing I did want to touch on was some of the more recent developments in prostate cancer treatment and management. And one of the things that's been talked about quite a bit lately are these different imaging modalities for prostate cancer. One in particular uses something called PSMA. And PSMA stands for prostate specific membrane antigen. And that's a long sort of jumble of words, but essentially think about PSMA like a targeted way in order to find where prostate cancer cells might be. So every cell in your body kind of has a signature. Some signatures are really general, like all cells have them. But cancer cells oftentimes will have a special sort of either a protein or what they call an antigen, which is a certain marker that only that particular type of prostate cancer will have. And the issue is researchers aren't always able to find what makes a cancer cell different from a normal cell. But when they find that, it's useful for both targeting. Targeting means you can be able to find where cancer cells might be before you can see them on a regular scan. And also you can use them for treatment. So imagine if you can tie together some radiation or tie together some chemotherapy to something that can target a particular cancer cell. So that's the general idea with these PSMA agents they use for imaging as well as treatment. That's kind of the promise that, you know, it's a more accurate, more targeted sort of approach. Thank you. And so right now it's sort of they've been doing the research on this for years, but we're kind of at the cusp of where these things have been approved by the FDA. And, you know, this is the beginning parts of some insurances are covering them, some insurances aren't. And the studies do show that they're better. So for instance, for imaging, in the past, you know, what a PET scan is a general sort of nuclear medicine test where they give you this radioactive sugar, and that's what's called F18. Because radioactive sugar basically images anything that is more active than the surrounding tissue. So what I mean by that is that your whole body uses sugar. So if something has cancer in it or it's growing like cancer, it takes up more sugar, not because sugar is inherently bad, because sugar is energy. So because the cells are growing faster, they take up more sugar and you can see them better on the scans. So as you can imagine though, that's not really specific to cancer. It could be injury, it could be infection, it could be inflammation. So one of the first sort of steps out of that was this one agent called Axumin. It was Axumin. And that was a prostate cancer specific antigen. And it was better than a regular PET scan, if you will. We've been using that for years. And, they're constantly trying to find something better. So now this PSMA antigen as a target was found to be about 2 times as sensitive and specific as the Axumin. So that's when you get into the different kind of names for the gallium-68 study. So this gallium-68, again, what it does is attaches itself to this PSMA and allows you to see things better. So really, from a patient standpoint, what it really means is when should you get that test? So not every person with prostate cancer needs to have that test. Because if you have a lower stage or a lower risk prostate cancer, the chance of having those cells spread somewhere is so low that putting you through an imaging study, whether it's the time, the money, or the exposure, isn't really worth it. So the ideal patients are those who either have a newly diagnosed prostate cancer that's a high intermediate risk or a high risk, because those are the patients that have a higher chance of having a cancer cell somewhere, or someone who's already had treatment, either a prostatectomy or radiation, and the PSA was low, and now the PSA is starting to rise a little bit. And you can't see the cells anywhere on a regular bone scan or CAT scan. Those are patients where these PSMA imaging studies are very useful, because if you find something that's positive, the specificity rate is very high, which means that if it's positive, it's real. But the sensitivity rate's only about 50 or 60%, which means that just because you don't pick it up, if your PSA is still rising, doesn't mean, there's not something there, you just can't see yet. So that's sort of the general patient, if you will, that would fit well for getting that study. So not every prostate cancer patient needs it, but it's someone who either has a newly diagnosed high risk prostate cancer or has already had their prostate cancer treated. And there's some concern that the prostate cancer could be back because the PSA is starting to go up. So I gave lots of information right there. So I'd like to open it up to anybody who has any questions, because again, I feel like a lot of times that a lot of people may have similar questions, so we can get some of those things answered.
Doctor, when you say the PSA goes up after you've had a treatment, generally after the treatment, it's like 0.1%, something like that. And what kind of rises do you see that you'd be alarmed by versus someone like me who's monitoring my PSAs and sees it go up by like a full point, and then I get concerned with that. I mean, how does that level of acceleration translate?
All right, so it sounds like you're basically asking what when your PSA goes up, what does it mean if it goes up rapidly or goes up slowly?
Yeah, kind of, and the range.
Okay. All right, so basically, with the PSA elevation, well, one thing first, someone asked me, where do you get that PSMA X-ray done? That's typically done at an imaging center that does a PET scan. So any imaging center that does PET scans would have the ability, but not all of them have that tracer yet. So the PET scanner itself is a piece of equipment, but the tracers can be different. So a normal PET scan, it would take what they call, F18. But, for a PSMA study, let's say, Partners Imaging, they have a PET scanner, but they'd have to actually be able to have access to the PSMA agents. Like one of them is called Hallucinex, another one's called Polarify. So that's what we do at the imaging center. All right, and so your question about PSA going up, it all depends on what your initial treatment was. So if you had a prostatectomy, which means your prostate was removed, at that point, your PSA should actually be close to zero, be less than 0.2. If your PSA raises above 0.2, the concern that your prostate cancer is back is real because you shouldn't have any prostate cells making PSA. If it's 0.2, but it's going up, 0.2, and then 3 months later is 0.25, and then 6 months later is 0.3, that's a fairly slow rise. So you don't always have to do something just because the PSA goes up. It's very case specific. Now, let's say that same situation, someone has a prostatectomy, PSA is 0.2, and 3 months later, the PSA is 0.4, and then 6 months later is 1.0. That represents a more rapid rise, and that's more concerning. And that patient will probably get put on some sort of treatment well before someone else with a slower rise. If you have radiation and your PSA starts to go up, it's a different definition because your PSA doesn't always go to zero after radiation. It may go to 0.1, it may go to 0.2, it may even be just 1.0 and still be, stable. If your PSA rises 3 consecutive times, that used to be the definition for PSA failure after radiation. The new definition is actually what they call nadir +2 for radiation. So that means that you get radiation, you check a bunch of PSAs every 3 to 4 months for the first couple of years. You find out what was the lowest PSA you ever had in that first couple of years. That's your nadir. So let's say you had a PSA every 3 months for 2 years, and your lowest PSA you ever got was 0.3. That would mean that until you get to 2.3, it's all fine. Once your PSA goes past 2.3, that's called a PSA failure. And at that point, that's when we start to look, okay, well, let's check to make sure the cancer cells aren't somewhere else. So following PSA and that rise depends on, again, initially what kind of treatment you had. And then it depends on the velocity or how fast it rises. Hope that makes a little more sense.
Well, my PSAs fluctuate between 6 and 9, so it's concerning. Then the highest it would be a 9, then would drop down to like a 6.5, and this is going on now for the past 2 years. So I'm trying to find out where my baseline is and whether or not I'm where it becomes even more alarming if it goes over 9, or how to monitor my.
Well, have you already had treatment?
I have not, no.
Okay, well, that's a different situation then. Like if you haven't had treatment, then at that point, monitoring your PSA is based on a new diagnosis. So, you need to see a urologist to track either MRI or get biopsies. So even getting these imaging studies I'm talking about doesn't really relate to your situation right now.
Well, do you think that repeat biopsies are in the cards for me? How often would you have to get a biopsy? I mean, it's not gonna.
It sounds like you've had biopsies that are negative already.
No, my biopsies were positive.
Okay, so you have known prostate cancer,
Right,
but you haven't been treated.
correct.
Okay, so are you currently on just observation or watchful waiting with your urologist?
Correct.
All right, well, if that's the case, you continue to do that until either your PSA continually goes up or they repeat the biopsy in about 18 months and if the Gleason score changes. So you just continue observation or until you don't want to do observation anymore. If doing observation makes you nervous, then you go get treatment.
That in a nutshell is what I did, I think,
Yeah.
essentially.
Yep,
What was
exactly
the
what Dave
highest
did.
you got before you went for treatment?
My PSA got up to 10.
And that was your ceiling when you made your decision?
Yep.
Okay.
Yep.
Doctor.
Yes, sir.
Yeah, hi, doctor. Thank you for being here. Is it okay to get dental and medical x-rays after you've completed radiation therapy a couple of months ago?
Most definitely. There's no interaction whatsoever, no danger whatsoever.
Oh, okay, thank you. Second
No
question,
problem.
quick. I've been off of Casodex for 5 months, but still have some breast tenderness. Is that kind of odd to be off of that for 5 months and still have that?
No, I wouldn't call it odd. You know, unfortunately, it's sort of in the wheelhouse of what can happen after the Casodex. You know, now it should get better within the next few months, but I've definitely seen it last for up to 8 to 9 months.
Okay, thank you, doctor.
No problem.
Would I be a candidate, doctor, for PSMA screening?
Is this the guy I was just talking to with the watchful waiting?
Yeah, yeah.
No, no, it wouldn't be. You wouldn't be indicated for one.
Yeah, you defined the examples of what PSMA really works best for.
Yeah. So basically, people who would be a good candidate for that would either have a newly diagnosed but high risk prostate cancer, so Gleason 8 or above, or high intermediate risk, so like a Gleason 7 with a bunch of cores positive, or somebody who's already got treatment, PSA was low, and then it started to rise again. So in your case, if you're on watchful waiting, then I'm pretty sure that you don't have a high risk prostate cancer because they wouldn't offer watchful waiting. So I don't think there's any indication or role for a PSMA test for you.
Interesting. Now, you were mentioning something about sugar interaction with PSAs. Is there something that would skew the PSAs or affect it if you had a high sugar intake?
No, there's no sugar interaction with PSAs. If I said that, that was misspoken. I said basically with the way PET scans work, PET scans take in radioactive sugar, but there's no interaction with your PSA and eating sugar.
But keep eating them Snickers bars.
Yeah, at least occasionally, not every day.
I had a PSMA done recently. I had a prostatectomy, and they watched it starting 12 weeks post-surgery. I had the surgery in October of 2020. So 12 weeks after that, I think it was, started. It started out at 0.02, and just a couple months ago had made its way to 0.5, and did the PSMA at that point, and they found one little culprit in the lymph node, like just south of the liver and gallbladder in there. And I just did SBRT radiation for that. And I'm waiting till May 20th to go back with, a PSA test and see what the next step the RO wants to do.
Yep, nope. I think that's exactly the right role for a PSMA and the right sort of treatment afterward. Since you had, like,
Believe me, I checked around, and you're absolutely right. Everybody had the same conclusion to do that. So I had no reaction to the SBRT. That went well.
and that's that's again a good example of why it's useful to get that test early like you did, because when it's a sole site or less than 4 areas of disease, oftentimes you can do something like SBRT because it's a smaller site and the smaller area that we treat, fewer side effects and still be highly, efficacious. So what they'll do is, what we hope to see in your situation is when you get the PSA in May, PSA drops down, that makes us more confident that was a major, the sole site or the main site of any kind of recurrent disease.
That's what I'm hoping for. I don't want to have to go through, ADT and 30 some days of radiation to the pelvic area and all that.
Right. So, and the PSA tests, like I said, are really specific, which means that, if they're positive, it's like 93% likely it's a true positive. So that's what specificity means in that situation. So
now you're doing PSMA tests in the Bradenton area?
Yes, yes, it's I know one imaging center for sure that's doing it. It might be two now.
Yeah, I had it done down in Fort Myers at a Genesis Center.
Yeah, I think that the up in Bradenton, Simon Med is doing them now.
Simon does them.
And they had to fly to how do you pronounce that? Polarify or whatever?
Yeah, Polarify.
They had to fly that in from a lab in Massachusetts, and I had to be sitting in the chair with a port in my arm waiting for them.
Yeah, the rep just came by recently and told me they got everything ready to start doing those there. So that's good for the area.
Oh, they're gonna set up a lab there?
Yeah, they'll be able to do Polarify studies.
That's good. I was surprised. I don't want to tell you the cost, but I was floored at the cost of that thing.
I bet.
What was the biopsy report? What was the Gleason score?
For me,
Yeah,
my Gleason before I had the prostate removed was a 7.
7, 3 plus 4 or 4 plus 3?
Yeah, I would think it was a 4. There was some that were 3 plus 4. What was it, done? 4 plus 3. 4 plus 3.
So it is the, it was the unfavorable 7. Okay.
Yeah. So yeah, that's what I'm saying. I'm just hoping that this was the only culprit. They nailed it. But I shall find out, that's for sure.
For sure. Any other questions in general about what we talked about? Any other questions?
Anything else from you guys? Just a quick note, a perfect example of Ed going to his wife, I presume, for information. I think that's classic. It's a good lesson for all of us to make sure we have somebody tied in with us as we go through this process. Very, very helpful.
Well, she ran a couple of offices in her lifetime, and she's the paper guru. Everything is organized.
So I guess I would also encourage, everybody on the line that if you've already got treated for prostate cancer, this is an example of why it's important to continue to get your PSAs checked, because there's no single PSA that ever tells you all yes or all no. There's always a trend of PSAs and what the PSAs are doing. And as I touched on, it depends on what your initial treatment was. So what I want you to remember is if you had a prostatectomy, like the guy that was just talking, it's more of an absolute cutoff, meaning that if it goes, if it's undetectable and it becomes detectable, that's a red flag. And that's when your doctor should be, checking you more, I guess, frequently, but then also now with these PSMA tests, that's a good candidate. So if your PSA was undetectable, and this is after prostate cancer surgery, becomes detectable, now what you're watching for, again, is the rate of increase. So if it's undetectable, but then it's, 0.05, it's not necessarily time to be alarmed, like, the world's ending. But you do want to start, okay, well, let's check this PSA and see how fast it's rising if it continues to rise. But after prostatectomy, it really shouldn't be, cycles where it goes up and down. It's concerning after prostatectomy. If you have radiation, a rise in your PSA is not as concerning because you still have prostate cells. Prostate cells make PSA, not just prostate cancer cells. So that's an important distinction, so that if you have had radiation after your prostate cancer, to realize that there's never a single PSA that tells you a lot. There's a trend of PSAs, you have to follow them, and then you have to get an idea of what that absolute rise is over your nadir. And again, remembering that the role of a PSMA test, so then now we're talking about the test for recurrence, is either after prostate surgery and your PSA is going up and you're concerned, or for initial staging, but only for a high-risk patient. Not every patient who gets diagnosed with prostate cancer needs to have that test. And that's because low-risk prostate cancers have a very, very, very low chance of spreading anywhere. So that's why the staging studies like the bone scans and the CAT scans aren't necessary for every prostate cancer patient. It really depends on what risk group you're
What did you say the name of that place was? It was doing the PSMAs?
in. Simon Med.
Simon Med?
Yeah.
There are treatments for if the prostate has, after treatment, your PSA dropped down to 0.2 after 2.5 years, it went back up anyway. And after taking the Axman test, it was discovered it's in the pelvic area, the 2 lymph nodes, microscopic.
Mhm.
And any treatments for that particular, besides hormone and shots and pills?
Yep. So in case you didn't hear the question was, you've had your treatment for prostate cancer, your PSA drops down, PSA starts to rise back up, you get an Axman study, which again is an imaging study similar to the PSMA, but just uses a different molecule. That Axman study shows a couple sites in the pelvis that are active or looks active on the scan. And what are your treatment options? So for a situation like that, you can either elect to do hormones and the pill, because that will cover everything. However, with the way our treatments are now, particularly radiation, if I had a patient like that, and I think the most radiation oncologists, if you have 2 or even up to 3 sites of where you could say disease, if you will, in the scan, I think that it's more than reasonable to just individually treat those 3 sites with localized radiation alone and then monitor, with the understanding that it's completely possible that we do a short course of radiation just to those sites, and on the next scan, some other areas appear because it could have been microscopic as you didn't see before. But if you do that and you get a good response, the benefit is you have a lot less side effects when you treat localized areas. So that's usually what most people are aiming toward now, because even if you treat those, let's say 2 sites now, and then let's say 6 months later, another site pops up, well, you can just treat that site. So it really depends. It gets to be a lot more patient specific, which is good because that means that some patients won't have to go on hormones or get systemic therapy if they can be treated, individual locations. But all that depends on how someone recurs, because not everybody recurs the same way. You can have 2 guys, PSAs can go up, and one guy may get a scan, an Axman scan or a PSMA scan, and it comes back and they have, 10 or 15 areas. That guy should be on hormone therapy. There's no role for just spot treating 15 spots. But somebody else might come back with 1 area or 2 or 3 areas. That's reasonable with close follow-up. So again, patient specific, and depending on the situation, the imaging, and how much time has passed since you had your definitive surgery too.
My PSA dropped down to 0.014.
Yeah.
Because I guess they couldn't detect below that. So,
Yeah.
That's been 9 months.
Okay. Other questions?
If the PSMA shows only 1 spot, and what is the false positive rate?
Yeah, so the false positive rate for the PSMA tests are pretty low. So I think it's less than 10% for false positive, because the specificity is about 90 or 93%. What the biggest issue with the PSMA test is the negativity rate, which means that just because it's negative, there's still a percentage of patients who could still have some prostate cancer cells there. And that's true of a lot of studies we do. But the idea that if you find a positive finding on a PSMA test, the confidence level that it's really positive is really high. So like, again, 90% or so.
Doctor, as far as regular PSA tests go, I shop online when I take my PSA test, and they have a regular PSA test, and then they have like a free, a more specific test. Is there any difference in those 2 tests for my monitoring purposes?
I think for your monitoring purposes, the most important thing is to compare the same number. So if you want to continue to pair the free PSA, you can do that. But most of the studies that looked at when you should intervene were just total PSA. So at this point now, since you already know that you have prostate cancer, I think I would just follow the total PSA.
Total PSA, not the free?
Again, as long as you're following the same one, they both will increase at the same sort of rate. But now that free PSA is more useful when you're trying to detect it. You're trying to detect if you have cancer, but you already know you have it.
Yeah.
So I would just follow the free.
Yeah. Because they're, yeah, that's different.
I was under the impression you cannot have any more radiation, but you're saying specifically target is possible?
Yeah, so this question is a really good one because you hear this often that once you get radiation, you can't have radiation again. That was, I would say years ago, completely true, depending on the area, with a big asterisk. And nowadays, definitely is very dependent on what you're treating. So let's say, for example, you get radiation to your prostate, and then you now have a recurrence in the pelvis. If you had your whole pelvis treated before, even then, it's not impossible because it depends on where this recurrence is in relation to your initial field. But if you had your prostate treated by itself, and now you have a spot in the pelvis, you for sure can get radiation again because that is not in the same field. So the reason it depends, and it's not just a, for sure you can't have radiation again if you had it once before. It's all dependent on what the field is and where it is you have to treat. So that's why it's important to kind of have that discussion so your radiation oncologist can look at the treatment you had and look at the treatment you need now.
Doctor, when I went through radiation 6 years ago, I guess, I was looking at all kinds of alternatives, even within radiation field, and one of them was called CyberKnife. And I kind of put that aside as not proven at that point, and that was 6 or 7 years ago. In the meantime, I've been hearing a lot more about CyberKnife, and I've also been hearing more and more about varied lengths of time for radiation treatments. Now, mine was, I think, a sort of standard 30-something days of treatment, but I hear more and more now about guys that are going through 10 days, 15 days, and I guess CyberKnife is really 5 days. What do you make of that? What should we make of it?
No, it's a good question. So basically, CyberKnife is a form of radiation. It's actually SBRT, just like what the gentleman was talking about he had to his pelvis. So it's the exact same thing. CyberKnife is just the type of machine that does SBRT. So CyberKnife is actually a machine that has like this robotic arm that has a linear accelerator in it, and it sort of tracks breathing motion a bit. But in essence, it's not, again, different than another linear accelerator that does SBRT. So SBRT means stereotactic body radiotherapy. So the gist of that is you give higher doses of radiation over fewer treatments. So instead of, say, 39 or 45 treatments, you get 5. Now, obviously, that's, everybody wants that. But what they don't tell you in a commercial is not everybody is a candidate for it. Because it has to be a certain stage of prostate cancer, a certain risk group. In terms of whether or not it's ready for prime time, to your point, Dave, over the last 5 or 6 years, more data has come out, looking at the 5-year local control rate, 5-year toxicity rate. So we do have more information. I think some of the longest data sets might be up to 10 years now, and it seems safe. So it's becoming more and more of an option. Still doesn't have, again, 20, 25-year data, if you will, on what happens long-term. What happens long-term to the urethra, what happens long-term to the exposed bladder and rectum. And I would say the safety profile is probably one of the bigger things that slows the adoption, and that only comes with time. But it seems to be working pretty well in terms of, prostate cancer control. But again, more time needs to go before it. I expect in the next 5 to 10 years, the percentage of patients getting it will continue to go up just because we'll get more data on the long-term side effects. And the same thing on these different numbers of treatments. This is what's called hypofractionation. There's more data, again, now on doing treatments for, let's say, a standard treatment can be anywhere between 3 weeks to 5.5 weeks. So there's fewer and fewer patients that get 8 or 9 weeks of treatment unless you're still having to treat the pelvis. So if you treat the pelvis because it's a high-risk patient, those patients still get more standard treatments because you get a lot more exposure to the small bowel. So to your original point, there's a lot of research and data on essentially trying to shorten the number of treatments that you get, but you have to weigh that against not wanting to increase side effects and toxicity. And a lot of times, only time tells what happens with that, with these different amounts of radiation daily. So that's why it sort of depends on the individual guy, because his prostate cancer situation may be different than the next guy.
Doctor, 2 questions. That SBRT, or that shortened service, is that offered in this area?
Yeah, I do it as well. I don't do it too often for primary prostate cancer, mainly because when I look at the data, I don't think the data is mature enough, but that's just my opinion. I know the people who do it, and particularly on the older guys, because, if you do it on someone to say, let's say he's, 80 plus years old, and I don't have a crystal ball, obviously, but, my concern with long-term toxicity on someone who's 85 may not be the same as somebody who's 65. But to your question, yeah, we do SBRT around here.
And secondly, that's not available for people with enlarged prostates and or that have had TERPs?
Correct. So those are some of the contraindications. So when you hear about these kind of treatments, to your point that you kind of pointed out, not everybody is always a candidate for it, because, when they talk about these things, whether it's commercials or billboards, they don't really have time to discuss all the reasons you might not be a candidate. And that's why you got to discuss it with whatever radiation doctor you talk to, because whether it's the size of the prostate, whether it's previous radiation, whether it's a TERP, whether it's the stage, whether it's the risk group, whether it's your Gleason score, there are a lot of things that go into play to determine whether you're a candidate for something like that.
So each dose is high for the stereotactic. Would that give more symptoms? Because I had the 40 treatments, very, very minimal symptoms, a little sleepiness immediately after. And after about 2 or 3 hours, there are no symptoms at all. If it is stereotactic and high dose given each time, would there be more symptoms?
Yes, it can be, and that's one of the things to look at in the data, that's one of the reasons why someone with a larger prostate wouldn't be a good candidate, because there's some suggestion you have more acute toxicity, means like during treatment, more issues with urinary obstruction or frequency or urgency. And then, that's not guaranteed, but you have a higher chance of it. And then there's also the more real thing about a higher chance of long-term toxicity, like urethral stricture or rectal bleeding, because the doses of radiation are higher daily. They have a higher what they call biological equivalence. So you can have more changes long-term. And you can't predict those changes long-term. You just you have to look at the studies. That's why we will talk about the data. What they're talking about is they don't have enough years yet to kind of look at a population of patients to say what really happens. So that's why it takes a while to adopt some of these things, in bigger parts of the communities.
Any other thoughts, guys? Questions?
Doctor, how soon should you have a PSA after you complete radiation?
I usually do the first one about 3 months after, at least 6 weeks. So, I would say between 6 weeks and 3 months is pretty standard. And even that first PSA is really just your new baseline PSA. It's not a PSA that's going to tell you, all yay or all nay. It just tells you where your PSA is after you finish, and then from that one, you continue to get one every 3 months.
So over the long haul, would you do it every 3 months or less than that?
I typically do it every 3 months for the first year, and then I'll do it every 4 months for the second year. Then I'll do every 6 months for years 3 through 5. Then I do it annually after that.
Okay.
And then if anything kind of happens where I see a PSA trend that seems to be going in the wrong direction, I can adjust it from there. So let's say we're on there every 6 months, but the PSA looks a little high. Maybe I go back and do it in 3 months to make sure it's in the right direction. But in general, if everything is going in, normally 3 months, then 4 months, then every 6 months, and then annually.
That's good to hear that.
And doctor, how often for someone like me who's in a watchful posture now, should I be testing?
If you're doing watchful waiting, usually I would do it every 3 to 4 months.
So I've been doing it every 3 months, and it's just been staying in that range, so.
We'll keep our clinic open.
Yeah.
Fingers crossed, yeah.
Well, guys, if there's nothing else,
Yeah, one question. If post radiation, if the patient is getting hormone treatment, the PSA level will be suppressed by the hormones. Is that right?
Correct. So if you're a high intermediate risk or a high risk patient, and you're on hormone therapy, your PSA will be depressed, usually down undetectable, just simply from the hormones. So when the hormones come off, it'll take several months for you to sort of recuperate some of your testosterone. So the PSA typically starts to come up a little bit, just naturally, and that doesn't mean your prostate cancer is back. So that's something to keep in mind. If you've been on hormones and then come off of hormones, that your PSA coming up doesn't mean your prostate cancer is coming back. It can just be your natural prostate cells that are remaining making a little bit of PSA.
Okay, thank you.
still gonna watch it, right?
Yep.
Did you want to ask about the genetics? Did you want to ask about the genetics?
Oh, yeah, there was a little bit of talk about genetics earlier, I think before you came in, and are there any specific things? I mean, guys should be doing genetic testing or?
For their sons.
Not every prostate cancer needs to have genetic testing on there. If you have a family history, multiple first degree relatives of prostate cancer, if you have any male breast cancer in the family, we have multiple like sisters with breast cancer even. And then, on top of that, if you have all those things and you have children, but not every guy with prostate cancer needs to have genetic testing. Again, I would say family history and or developing prostate cancer at a young age, say like, in your 40s or something or below.
Well.
All right, gentlemen.
Doc, what about, just to reemphasize, if there's female or male relatives with breast cancer, if they have BRCA gene?
Yes, completely. So
men don't think about that relationship, but it's a very important relationship.
Agreed 100%. So to Andy's point, if you have someone in your family and the BRCA1 and BRCA2 gene are genes that typically women test for when they get breast cancer. And not every woman gets tested for that, of course, but again, it's a family history sort of thing. But if you have someone in your family that tested positive for that, it also increases the chance that you can have, a copy of that gene, and it could be the source of your prostate cancer. So it's a good idea to test yourself if you have someone in your family that tested positive for BRCA1 or 2.
Well, Dr. Fitch, we can't thank you enough for this presentation. You certainly filled up a lot of the gaps in our knowledge, and that's a really huge help.
Sounds good. Glad to see everybody, at least virtually, and the people I have here. So everybody have a great rest of your day.
Thank you very
Thank you,
much.
Dr.
Thank you.
Thank you, guys.
Thank you.
Thank you, guys. Thank you all. We'll see you again in a month. Any questions in the meantime, feel free to call me and I'll get them to the right place.
Okay.
Right.
Not the right place myself, but I'll find the right place. All right, have a great day, guys.
All right, you too.
Thanks.